So today my topic is going to be decubitus. Why decubitus? Because I just came from trying to explain to one of my students what a decubitus is, and reason being we have a patient, we got a patient today that has an open wound on their body. Now when we admit patients into our ward, there are a couple of questions that we ask them, and one of them is we try to get information from them about their physical condition, their medical condition, the medications that they take, on just to get a better feel of them and to know about them. And one of the questions that we pose while we ask this, get this general information, is if they have a wound on their body, or if the wound is open, whether something hurts. And the reason for that is we want to determine if a patient leaves the hospital and they claim to have gotten a decubitus, or we want to determine whether they came with the decubitus or whether they got the decubitus from the hospital. When they come with the decubitus, we want to basically have a progress report on how we dealt with the decubitus, whether it worsened or whether it got better while they were on the hospital ward. Now, like I said, my topic today is decubitus, or what we would normally call a bed sore, or a decubitus ulcer, or a pressure ulcer. Now, what's a decubitus? It is a pressure ulcer, like we said. We normally get it on our skin or underlying tissue from prolonged pressure on the skin. There's two factors that we look at when we think of a decubitus. We think of the pressure and we think of the time. So a decubitus mostly develops on area of the skin that covers mostly where bone is. For example, the heels, the hips, the side of the knee when the patients sleep, the side of the face as well, the cheekbones, the back of the head, the shoulder blades, the spine, the tailbone, sometimes even behind the knees. It depends on where the pressure point is, and it depends on what amount of skin or tissue someone has around a bone. Now, for us to be able to understand what a decubitus is, we need to understand our skin, what it's like, what it is, how it functions, and the layers of the skin. The skin isn't just what we see on the top. Now, the skin is the largest organ of our body. Now, there's many reasons why the skin is very important to us, but the three main reasons are to protect us from microbes and other elements, to regulate our body temperature, and also to permit sensations, different sensations of touch, of heat, or cold. Now, the skin is much more than what we see. The skin has three different layers. We have the epidermis, that's the outermost part of the skin. This what you see. It consists of three different types of cells. We have the squamous cells. That's what sits on the outermost layer, and that's what we shed continuously. It's called the stratum corneum. We also have the basal cells. They sit just under the squamous cells on the base of the epidermis, and then we also have the melanocytes. They also sit on the base of the epidermis, but the reason why the melanocytes are important for us is because they give us our skin complexion, our skin color. The dermis is the second layer of the skin, and it consists of very many things. It consists of hair follicles, blood vessels, lymph vessels, collagen bundles, the sebaceous gland as well. It consists of the sweat gland, pain and touch receptors, and it's held together by a protein called collagen. That's what gives our skin the flexibility and the strength. The subcutis or hypodermis, or what we call the fat layer, is the deepest layer of the skin. It consists of a network of collagen and fat cells, and it helps conserve the body's heat, and it protects the body basically. For example, when we fall, it's what absorbs the shock. So what are some of the warning signs that a decubitus is round about the corner? It's an area of the body that maybe feels warmer or colder than usual. It is swelling, pus-like drainage, or even just unusual signs, unusual changes in skin color or texture, or even just tender areas, a patient will normally convey to you when an area becomes tender. So let's talk about the causes of a decubitus. The first cause, the most common cause, is a poor blood circulation, and that is caused by pressure to this area. We know that blood provides oxygen and nutrients to our body, and when our skin or the underlying tissues do not get this oxygen and nutrients, there's no blood circulation, which causes a decubitus. The second cause could be friction from moving our body parts, the skin rubbing against each other, or shear is basically when two surfaces rub together, and that's not only the skin, that can also be the material that we lie on. For example, the bed sheets, when we move the patients, when we turn them, when we readjust their positions, we move them on these materials that could cause a decubitus. Think about the risk factors. When you get a patient that comes to the hospital, there are certain things that you notice that could cause a decubitus. For example, the patient is aged. Patients over 70 or patients that have weak skin, what weak means old skin, that is susceptible to tear and damage, could easily get a decubitus. Patients that are obese could easily get a decubitus, because remember we talked about shear and friction causing the skin to rub against each other. It could cause a decubitus. Incontinence of a patient, because the area is always wet and it's exposed to urine and stool, patient could get a decubitus. Immobility could be caused by anything. Either a patient has had an operation, or they're just at the stage where they cannot move because of a medical condition. It could also cause decubitus. Lack of sensory perception. Now, this is caused by either spinal cord injuries or neurological injuries, or even the inability to feel pain and damage to the skin. Poor nutrition and hydration, and that's why we normally give the old patients that are immobile an infusion, so they have some fluid in their body. When they get dehydrated, the skin is susceptible to tear and damage, and also when they don't get the proper nutrition, then the skin gets damaged much easily. Like we said, medical conditions, for example, diabetes or kidney disease, diseases that, or even vascular diseases that restrict the flow of blood and oxygen to the body, could cause a decubitus. I guess those are mostly the conditions that could really cause a decubitus. Now, how do we avoid getting a decubitus? The first and foremost is to keep the skin clean and dry. For patients that wear the incontinence materials, you change them when they're wet. You clean them up when they're soiled, just to avoid the area being wet and moist. Frequent shifting of the positions, and that should be in an interval of 2 to 3 hours, every 2 to 3 hours, so they're not lying on the same position like the whole time. The best would be to encourage mobility, but if the patients are not able to move, then we can do certain exercises with them in bed, try and move their body parts that are especially stiff, so that they don't get a decubitus. The other thing could be also wheelchairs or beds or special cushions they could use. We have a cushion that we normally use here at the hospital that is a gel cushion, but you will notice that for patients who have a wheelchair or some sort of property that they came with to help them, because they're sitting or lying most of the time, they have certain specific cushions that will be prescribed for them by their doctor, that they will use to kind of help shift their weight evenly when they sit or when they lie down. Another thing that we could do is to protect the skin. Now, you'll see that normally when we're caring for patients who are lying, we will cream, we'll put cream, or when we're done preparing them in the mornings, we cream. We put lotion in their skin so that they can the skin can get moist and, preserve the fluid that we have in our body. And then we also have to inspect the skin daily with the finger test. The finger test is when you press your skin, you expect it to bounce back. And that also shows your hydration levels. If your skin remains in when you press it, then that means you're not hydrated enough. But for mostly patients who will be getting a decubitus, when you press, the skin also remains in. And that's for different reasons. Like we say, they're either having not a proper diet or they're not hydrated. A decubitus comes in different shapes and forms. We call them stages. Now, the first stage, there's 4 main stages. The first stage is stage 1. There's redness, there's this coloring, but the skin is still intact. But you will see the swelling on the skin. When you do the finger test, the skin remains with a dent. It's itchy, it burns, it's warm to the touch. There's every other symptom except for the skin is still closed. In the second stage, the skin is cut, or there's a shallow sore. It could be a blister filled with liquid. Well, the surrounding area is discolored. It's mostly the epidermis, the top layer of the skin, that is affected. In stage 3, the wound goes much deeper. It goes through the epidermis, the dermis. In stage 2, by the way, the dermis could be affected as well. In stage 3, it goes all the way to the subcutis, but we do not see any bones or we do not see tendons. The wound may be smelly, it may be foul. In stage 4, we take all the characteristics of the wound. It's open, it's sore, it's discolored. We see the first 3 layers of the skin, and we could even see bone, tissue, tendons, muscle, or joints. You will normally see, and there are going to be pictures that could be disturbing, but most of the time you will see a wound that's necrotic. Basically, a necrotic means it is dead tissue. It's black tissue. It's dead. It hasn't received any nutrition or oxygen in the last couple of, or for how long they've had the wound. In the 4th stage, you will normally see eschar or slow. That comes with the deepness of the wound and how necrotic the skin is. Now, there are very many different types of treatments, and the treatments also depend on the stage at which the decubitus is. If you are stage 1, the best you can do is to use a cream on the area that is affected, keeping the site clean and dry, repositioning frequently, like we said, the 2 to 3 hours, using different repositioning tactics. For example, using a cushion or just changing the position of the bed, and also keeping the skin free of irritants. Other treatment may include specific wound dressing recommendations or even antibiotics, which could also be oral cream or intravenous. Using specific bandages that remove this debris on the wound, or for example, we have the Superzorb, or sometimes we use the Lomator as well. Medication to relieve pain could also be used. Surgery is the most common one, where the doctors will do the debridement or removal of the dead skin that they will find in the wound. Specific offloading cushions, or cushions that will help distribute weight. Dietary recommendations, or staying hydrated, exercise, or increasing mobility, and also the last specific one could be specific padding. We have specific padding that we use for patients, especially for the heels and the elbows, when they have an area that is turning red, or if they have a wound, so they don't put this skin tissue directly on the beds or the materials that they sleep on. Well, the newest method that I've seen doctors use is they use maggots that they put into a specific carry bag that they put into, especially for patients that have very deep wounds, that they put it in so the maggots can kind of eat away on the damaged tissue. So let's go back to the beginning. We've received a patient, we've found out that they have a wound. How do we describe a wound? How do we describe a decubitus? But is a topic that will go much more into detail when we talk about wound management, which will be another video. But some of the things that we need to record are the diameter of the wound. How long is it? How wide is it? How deep is it? We also record the smell. We record the moistness or the dryness of it. We also record the stage of cure that it's at, and that's also will come up when we talk about wound management. There's a couple of things that we use to describe what the decubitus is like. The color of the surrounding tissue. Is it necrotic? Is it just red? How tight the skin around it is. But again, that all comes up in wound management. So always remember that when we ask you to, especially students, I know they feel like we shouldn't be positioning the patients all the time, especially during the night. I'm on a night shift right now, but you tend to want to think, oh, I'd like them to sleep, maybe to sleep a little better. But this is only to their advantage, repositioning them frequently so they have their tissue intact, especially for patients that may have underlying medical conditions like diabetes, because when these patients get wounds, these wounds never cure, or it takes a really long time for them to cure. Like again, we will look at all that in wound management and how long it takes for a wound to get cured, or they actually even get cured.